Hello and welcome to the annual lecture 2025 of the Healthcare Improvement Studies Institute and Homerton College. My name is Niels Peek. I am Professor of Data Science and Healthcare Improvement at this institute. And I have the honor of giving this year's lecture. My background is in computer science and AI, and I'm interested in how we can improve healthcare services using data-driven technologies such as artificial intelligence. So that's what we're going to talk about today. And I'm sure that you've seen some of the headlines about AI and specifically the use of AI in healthcare over the last 5 to 10 years. So here's one. This is actually from 2018, so a couple of years ago now. Doctor won't see you soon. Computers will replace doctors in just 10 years, says Health Secretary Jeremy Hunt. So Jeremy Hunt was the Health Secretary at the time. And this, I believe, was from The Sun. And I'm actually not entirely sure whether Jeremy Hunt said exactly that, but it is the message that The Sun felt was the most interesting to convey. Um, and here's another couple of headlines. And on the left-hand side, there's one, something that Jeff Hinton said. And Jeff Hinton is considered to be one of the godfathers of modern AI because he was very important in the development of what we now call deep learning. And he said in 2016, people should just stop training radiologists now. It's just completely obvious that in 5 years, deep learning is going to do better than radiologists. So this was in 2016. It's now 2025. I think it's fair to say that that hasn't really happened. Jeff Hinton did win the Nobel Prize for his work in AI in 2024, so just a couple of months ago. I don't think it was for this particular prediction, but really for all his work on deep neural networks and deep learning. In this lecture, we're not going to add more predictions. I think there's enough prophecies about AI and AI in healthcare already. We're going to look back a little bit and look at the history of AI in healthcare and consider what we can learn from that history. And I think it's important to realize that the history of AI and AI in medicine is quite long, longer than most people realize probably, and very rich. So it depends a little bit on how you define it, but I'm inclined to say basically that history of AI started already in the 1940s, in 1943, when there were two mathematicians who came up with a mathematical model of a neuron, and they called it the artificial neuron. And that's still the basis of all neural networks, artificial neural networks that we use today in deep learning. So that was a pivotal moment, I would say, and you could argue it's the start of the discipline. The term artificial intelligence was first used in 1956 at a conference or a workshop in Dartmouth in the US. AI in medicine is a field that kind of emerged in the 1970s, 1980s. The first AI in medicine conference was in 1985 in Pavia in Italy. Another couple of pivotal events in 1997, there was a chess computer from IBM, Deep Blue, who beat the then world champion in chess, Garry Kasparov. And then in 2012, there was a deep neural network called AlexNet, who won a competition called ImageNet. That was all about recognizing images, and didn't just win that competition. Very soon thereafter, there were deep neural networks who were better at recognizing images than people. And that was an enormous breakthrough. More recently, we've had other breakthroughs like ChatGPT and related large language models who are very, very good at natural language. So it's a rich history and it goes back quite a long time. In the talk today, we're going to focus on basically the last 25 years, and that coincides with my academic career in the field. Back in 2000, I started working as a postdoc researcher at the University of Amsterdam, and that was in this beautiful building that we see over here. I remember at the time when I told people I work in Amsterdam, they would all say, "Oh, Amsterdam, it's so beautiful, and I would always invite them to visit me at my office. I worked at a small Department of Medical Informatics, and we see them here. And we looked at the use of computers and information in healthcare very broadly. And it's actually quite interesting to compare what has changed between then, 2000, and now in terms of the use of computers in healthcare. So in 2000, there were still paper-based records everywhere in hospitals, in healthcare. Whereas in 2025, nowadays, basically, there's almost everywhere electronic health records. In 2000, there were actually very, very few computers that you would see in a hospital, whereas nowadays there's computers everywhere. Um, if there were computers, they were typically using outdated systems. Sadly, that hasn't really changed. There are different systems now, but they're still quite outdated. If you go to the NHS, then you find that unfortunately a lot of the systems that are used are a bit or outdated. In 2000, most clinicians didn't like computers. Um, I think it's fair to say that that has somewhat changed, although a lot of clinicians don't really like computers still in their job. They might like them personally in their personal life, but they often have to work with outdated and very clunky systems in the NHS, and therefore they don't really like that to doing that. And then finally, in 2000, there was no artificial intelligence, whereas now, I think it's fair to say there is some AI, although it isn't probably as widespread as some of the headlines that we were looking at previously tend to suggest. So let's talk about artificial intelligence. And I'm going to start with a couple of definitions. I've got four here on the slide. There's a lot more definitions around. So the first one from McCarthy, John McCarthy, is from that workshop I mentioned earlier that was held in Dartmouth in the US in 1956. What's interesting, if you look at these different definitions, is that our ideas about what AI is has changed over time. And it's probably fair to say that, if we in the future, say in another 25 years or so from today, it's probably going to be different again. Um, my personal favorite from these four definitions is the one on the top right from Eleanor Rich. So that one says AI is getting computers to do things which at the moment humans do better. And I've actually heard a variant of that one more recently, which says that AI is everything that computers can't yet do. Once they can, it's just software. We don't call it AI anymore. And I think that's actually quite true. So when I was a student back in the 1990s in computer science, and we talked about AI, one of the examples that was given was spelling checkers. And it was said in the future, we're going to have AI and that will be able to do spelling checks of, a document that you write. Nowadays, we wouldn't consider that to be AI. That's just software. That's not very intelligent at all. So I think, what we consider to be AI is shifting all the time. Um, Another way to think about AI, rather than looking at these different definitions, is thinking about what are the tasks that we want AI to perform. And I think this tree here is very useful in thinking about that. And it uses a distinction that we typically use in AI between what we call formal tasks, which are on the right. So these are things like maths, but also games like chess and checkers and Go. Then in the middle, mundane tasks. These are things like seeing, using natural language, common sense reasoning. And finally, expert tasks, which are things like engineering, scientific analysis, financial analysis, and also medical diagnosis. And obviously, the thinking is that on these expert tasks on the left-hand side, that's where the real value is for AI. And it's interesting to note that medical diagnosis has been, in the textbooks about AI since decades as one of the key areas that we want to solve or at least support with AI. So that goes back a very, very long way. And it's always been high on the wish list of AI researchers to support it. Um, and as an example, here's a paper from 1959 from Science, from Robert Ledley and Lee Lusted, which argued that medical diagnosis is a problem that can be cast in mathematical terms. And for that reason, we should be able to do it with computers. That's what the paper said. So ultimately, it is a problem that we can solve or support with AI. I said earlier that in the year 2000, there was no AI in hospitals. That wasn't entirely true, actually. There was some AI because already at the time, in every electrocardiograph, there was some software embedded based on rules that would classify the signal that was measured, the electrocardiogram. So in this particular example, for instance, it says this ECG is normal and there's a normal sinus rhythm. And this is based on fairly straightforward rules like we see here. So for instance, if the heart rate is below 60 beats per minute, then the classification or diagnosis is bradycardia. If the heart rate is above 100 beats per minute, then we say it's tachycardia. And this goes on. So there's also a rule for atrial fibrillation, for myocardial infarction, and for bundle branch block. So these are fairly simple, straightforward rules. They are typically derived from established cardiology guidelines published by professional societies like the American Heart Association or the European Society of Cardiology. And this is an extremely widespread form of AI because it's embedded in all the electrocardiographs around the world, basically. What's also very interesting is that despite the fact that it's very widespread, it's also very widely ignored. So basically every junior doctor is told, oh, don't look at that. Just ignore it. And the reason why it's generally not considered to be very accurate is that it completely ignores the context in which this ECG was produced. So, for instance, it ignores the patient's medical history. It ignores whether they had been diagnosed, for instance, with atrial fibrillation or any other cardiological condition previously. It also ignores why we made this ECG in the first place. So for all those reasons, it isn't very accurate. So these rule-based AI systems were basically the predominant type of technology in the field for quite a long time. They emerged in the 1970s and then were used to build systems like the one that we just saw. But I was also involved in developing a system back in the early 2000s that provided decision support for cardiac rehabilitation based on the clinical guidelines that were used at the time in the Netherlands. And this was such a rule-based system. What we did here is make sure that at the time that the guidelines were developed, we also developed the decision support system, so the rules for that system in parallel. And because we did that, we could ensure that the guidelines and the system were saying exactly the same thing. And that was really important for the acceptance, the clinical acceptance of the system. And what we were able to demonstrate is that this system actually led to better decision making, or at least decision making that was closer to what was typically recommended by the guidelines. And we had a number of different domains in which decisions were being made. So exercise therapy, education, relaxation therapy, and lifestyle change coaching. And apart from that last category, we saw that there was a clear and significant increase in guideline fidelity. So decisions that were made by the cardiac rehabilitation teams were closer to what was recommended by the guidelines. So a clear success. So in 2014, I moved to the UK and got a job at the University of Manchester. And I landed there in a very vibrant community, informatics and digital health community, with lots of researchers active in the area, but also an ecosystem in the city region of Manchester with other organizations interested in informatics and digital health. And one of the benefits that we have in the UK and we don't really have in the Netherlands is that we have electronic health records and a unique identifier for each person who lives in the UK. And that makes it relatively easy to use these electronic health records in large-scale studies to evaluate interventions. So one of the studies I became involved in was the evaluation of another AI system, again using these rules like we saw before, but in this case, a system used in general practice to improve the safety of medication prescribing. And here are the results of the study that we undertook. We used here data from about 500,000 people across more than 200 general practices that used a commercial decision support system that generates alerts whenever the GP is trying to prescribe a medicine that is potentially harmful. And this is then obviously dictated by the rules embedded in that system, and they are based on national prescribing safety indicators like the pincer indicators, the stop-start criteria, and these are all written into the NICE guidelines. And what we found is that after 2 years, there was about a 10% reduction in patients exposed to such potentially harmful prescriptions. And we see that here on the right-hand side of the graph, the difference between the blue and the orange lines, the purple lines, is that 10% difference, 10% reduction that we found after 2 years. So 10%, that's quite a modest reduction. It's still a huge improvement if you consider the number of medicines that are prescribed every day in general practice, and that's an enormous number. So just a couple of takeaway points about this type of AI, rule-based AI. So typically these systems are aimed at improving the quality of clinical decision making. The content usually reflects established medical practice, so the things that are written into clinical guidelines. These kind of systems have been extremely well studied, so I've shown you a couple of examples. But for instance, there was a review of these systems, systematic review that was published in the BMJ a couple of years ago. Main lead author called Kwan. So that review covered 122 trials, 1.2 million patients, and 10,000 different providers. What the review found is that this type of technology mostly achieves small to moderate improvements in processes of care. So the 10% reduction in potentially harmful prescribing that we found in our study is quite exemplary of what we typically find with these systems. It's not enormous improvements that we find, but small to moderate improvements in process of care, in this case, clinical decision making. One of the issues is that sometimes we do find substantial process improvements. At other times, there's no improvement at all, but we don't know exactly why that happens and when it happens. So we don't know what the predictors are of these differences. So that's a kind of an unresolved question, despite the fact that there have been so many trials in this field. So let's move on and talk about machine learning. So rather than trying to formulate a set of rules that govern the behavior of a computer program, it can be easier sometimes to train a system by showing it examples of the desired input-output behavior. And this has now become the dominant way of using AI and to some extent even programming computers. And most of the progress that we've seen in this area over the last years has been driven by the development of new learning theory and new machine learning algorithms, but also the ongoing explosion in the availability of data, and also to some extent the fact that there's more low-cost computation available nowadays. And this trend, so moving from the rule-based approach to the machine learning approach, is something that we've, for instance, witnessed in the AI in medicine conferences. I mentioned earlier that the first of those was held in 1985, and since then, every 2 years, a conference was held at different places. About 10 years ago, we analyzed all the submissions to all the papers that had been published as part of that conference, the conference proceedings, until 2013. And what we clearly saw is that in the early years, the conference was completely dominated by the rule-based approach. So we call that knowledge engineering, and it's at the top of this graph, the big green dots. Whereas later on, machine learning and data mining became more dominant, and the knowledge engineering approach kind of disappeared from the conference. So one particular area where we use machine learning is in risk prediction models. And I've done a lot of work with colleagues from Manchester in this area. So a risk prediction model typically takes a set of predictors, which are the relevant characteristics of the person for whom we are making a prediction. So that could be things like age, sex, medical history, findings from medical examination, clinical examination, and lab results. But it could also be, for instance, a polygenic risk score or anything else that we know about the person. And that feeds into a machine learning or statistical model that produces conditional probabilities. And those conditional probabilities we can interpret as the risk that that person would experience an outcome of interest. And typically that would be something that we would like to prevent. So these risk prediction models help us to identify people at high risk of a certain event that we want to prevent. And so we can apply preventative measures to those high risk patients. So one project that I'm leading here in Cambridge evaluates this type of technology in the context of reducing pressure to urgent and emergency care. And it uses a risk prediction model based on AI to identify patients who are at risk of an unplanned hospital admission in the next 6 months. And if they are, then they are being offered clinical coaching, which helps them to better self-manage their condition and, for instance, identify useful healthcare resources in the community. So it's great to be working on a real-world deployment of this technology. So this is happening in Northeast London. And that's all the more interesting because if we look at these risk prediction models, there's hundreds being published every year, but very, very few are actually making it into clinical practice. And this is a growing concern in the risk prediction community. There's this deluge of new models being published in the literature, but we don't see much impact on clinical practice. We see similar figures here in this dashboard, the global clinical dashboard for artificial intelligence. The blue graph here displays all the studies being published worldwide in healthcare AI. And the orange graph or amber graph are the so-called mature studies, so studies that look at the deployment of healthcare AI in clinical practice. And we see that there's an enormous gap between the two. There's been an exponential growth over the last 10 years or so in the total number of studies. There's also been a growth in the number of mature studies, but the gap is actually widening. So we have more and more development of AI, But the number of studies evaluating the value of that AI in clinical practice is very much lagging behind. And this brings me to one of the final topics of this talk, which are what I call the riddles of innovation. So when I was in Manchester, I became the director of the Christopher Pankhurst Institute in 2021. And that's the University of Manchester flagship institute for health technology research and innovation. And its key mission was to accelerate the innovation of healthcare services using novel technologies. And this journey of scientific discovery to practical innovation in the real world is often viewed as a linear process involving a number of critical steps, none of which can be missed in order to be successful at the end. So this particular model that we see here, for instance, is from Gannon. It was published about 10 years ago. And it moves from discovery to implementation. And the role of health researchers in this model is typically to provide evidence that a particular stage has been completed. For instance, that there is evidence of efficacy, say, and it allows the discovery to move then to the next stage. So researchers have a gatekeeper role, if you will. And it's sometimes said that the overall journey from left to right on this slide takes 17 years, and that there are particular transitions here that are particularly challenging, and they're called the valleys of death. My personal opinion is that we don't really have evidence that either of these two things is true, but that's what the typical legacy is. So in the last phase of this translational pathway is where the actual innovation takes place that has an impact on the real world. And for digital technologies, it is also the phase where users define what the technology really is. And this was, I think, very well expressed by Steve Jobs many years ago now when the iPad was introduced. And Steve Jobs appeared at a press conference and showed the iPad and said, well, we've developed this thing, but now you have to figure out what it really is and what it is good for. And that's quite an extreme view, but I think it has some truth for all digital technologies. Only once people start using digital technologies, we figure out what they really are, how we can best use them, and what their value is. If that is true, then this linear translational pathway is almost meaningless for digital technologies. Because if we only figure out at the very end what the technology really is and how it achieves its value, then all those previous steps are impossible. And I think that's the reason that some people believe that this translational pathway model isn't really working for this kind of technology. And instead, they believe that innovation emerges from well-functioning innovation ecosystems, where different types of stakeholders can easily interact with each other. And each of these stakeholders brings an essential piece to the innovation puzzle, be it knowledge, skills, money, or governing power. And in this model, academic researchers are not so much gatekeepers, as in the linear pathway model, but just one of the stakeholders in the innovation ecosystem. I think it's fair to say that we're still exploring what innovation actually looks like in that kind of innovation ecosystem, what the processes should look like. And one approach that we're focusing on at this institute is the idea of a learning system. And in a learning system, we have a cyclical process that begins with building a really solid understanding of the problems at hand. And from there, we move on to designing and testing potential solutions, always working closely with the people who are actually experiencing those problems and therefore know best what also possible solutions could be. I think this solid understanding of the problems at hand and close collaboration with the people who are experienced problems is what characterizes what we do at this institute. As I mentioned earlier, I joined the institute early last year and very excited by the things that the capabilities that the institute has, especially for digital healthcare innovation. At the beginning of this talk, I mentioned how medical diagnosis often comes up in almost every book on AI as a major task that we either want to support with AI or sometimes even solve or replace entirely. But if you actually speak to clinicians, very few of them would say that diagnosis is what they really need help with. What they will say is that they're swamped with tasks that eat up a huge amount of their time, admin, documentation, coordination, and those are the areas where they need support. Diagnosis rarely comes up as a top priority. More broadly, I think it's fair to say that we haven't quite cracked how to use AI to drive innovation in healthcare service in a way that truly meets the needs of the people who work there. And I think it's very nicely expressed also in this tweet that went viral last year. I want AI to do my laundry and dishes so that I can do art and writing. I don't want AI to do my art and writing so that I'm left with the laundry and the dishes. It's not different, I think, in healthcare. So that brings me to the last topic of this lecture, which is ambient voice technology. So ambient voice technology, sometimes also called ambient scribes or digital scribes or AI scribes, basically transcribe the conversation that clinicians have with their patients and then summarize that transcription into a meaningful note that goes into the electronic health records. So that means that clinicians, when they see their patients, don't have to do documentation of the consultation. They can just leave that to the ambient voice technology. And this is technology that is has been taken off over the last 12 to 24 months. I heard last week, I think that there are now more than 100 companies worldwide offering this technology. And that's incredible because I think it's fair to say that more than 2 years ago, there were none because it didn't exist. And also a lot of NHS organizations are now adopting this technology. So it's quickly making its way to the front line. Ambient voice technology is at the moment still an unregulated technology because it's not considered to be a medical device. That's also the reason why it can make its way to frontline clinical practice so quickly. It is quite remarkable that it isn't regulated at the moment because if you think about the potential effects that this technology can have, they are, substantial. I'm very excited that we're currently starting an evaluation of this technology in primary care, where we're specifically going to look at clinician time. So how the use of digital scribes leads to a repurposing of how clinicians, GPs in this case, spend their time. So let me wrap up with a couple of key points from the lecture. So we spoke about rule-based AI, the old form of AI, and we know from a very large number of trials that have been undertaken with that technology is that it tends to lead to modest improvements in clinical decision making. What we don't know, we can't really predict when that's going to happen. So sometimes we've got modest improvements, sometimes we've got more than modest improvements, sometimes nothing improves. But our understanding of when that happens is still relatively poor, despite that large number of trials that has been done. Machine learning, the new form of AI, offers promising opportunities, new opportunities, but its value for healthcare services remains entirely uncertain, I think, at the moment. We really still need the evidence before we know whether it would lead to more improvements than with the old form of AI. I think it's fair to say that tech developers often prioritize so-called expert tasks like diagnosis, where healthcare staff are more interested in support for mundane or routine tasks. And finally, I think we need a clearer understanding of how AI can be effectively integrated into healthcare systems, because there is this enormous gap between the number of AI models that are being developed and the number of models that actually make it into clinical practice, which is very, very modest at the moment still. So I'd like to thank my collaborators, the people with whom I've worked over the years across various projects, and I'd like to thank you for listening. And here on the final slide, you can see how you can stay in touch with us and hear more about our work. Thank you very much.